So, good morning. Thank you for that introduction. I thought I would take a page out of the prostate guy's book and spend a whole hour talking about one molecule. So I always say in bladder cancer, for the longest time, we've sort of lagged behind the progress that we've seen in kidney and prostate cancer. And I always say it's because we don't have our androgen receptor or our VEGF signaling pathway. But one thing that is becoming more and more important in bladder cancer is FGFR signaling. So can any of the residents tell me what FGFR is, just what it stands for? So fibroblast is the F. So why talk about FGFR? So FGFR3 is one of the most important, most commonly altered genes in bladder cancer. I'm sure the residents have at least heard that before. The thing that you might not know is that an FGFR inhibitor was approved for second-line metastatic urothelial carcinoma just last week. So this is something that we will encounter in clinical practice. Currently, of course, in the latest stage, but it will most likely move forward. And then you know that immune checkpoint blockade is the latest rage in all of cancer, but especially in bladder cancer. And there are interactions there between FGFR and immunotherapy, which are interesting. So I'm going to sort of roughly talk about these topics, of a bit of a meandering talk, and then I went back and sort of made an agenda that might or might not fit to it. But we'll talk a little bit just in general about FGFR3, or FGFR, but especially FGFR3 in bladder cancer, how to target FGFR, the interplay between FGFR3 and the immune system, a little bit about mechanisms of resistance, just because it's interesting, and then some of the ongoing clinical trials. So FGFR, the AR of bladder cancer. So as with most of these types of receptors, they're cell surface receptors that, does this work? It doesn't work on the screen. So the mouse. So if you, this does, yeah. So they are monomers, and when ligand comes, and there are 22 different FGFs, so fibroblast growth factor, when the ligand binds, you get this dimerization that leads to phosphorylation intracellularly, which activates a bunch of different pathways. Most of these pathways in FGFR signaling are related to proliferation. So things like RAS, MAP kinase, are things you might have heard of, and PI3 kinase, AKT, etc. So it's sort of a classic growth factor receptor pathway. It's known that if you have germline mutations in FGFR3 or other, either the receptors or ligands, you can have a lot of bone problems. And so, for example, FGFR3 mutations, this S249C is the most common hotspot mutation you see in bladder cancer, but you also see it in achondroplasia. And it all relates to phosphate metabolism. And one of the things you'll see about the FGFR inhibitors is that they cause hyperphosphatemia as one of their side effects. So these mutations have been known for a while, before they were described then in cancer. In bladder cancer, it's mostly about FGFR3 mutations, but there are a lot of other FGFR alterations. So there are 4 FGFRs, first of all, 1, 2, 3, and 4. And you can see you may have just wild type overexpression. You can have overexpression due to gene amplification. So we see FGFR amplification. You can have mutation in the extracellular domain, which is what we usually see in bladder cancer. And what happens is if you have a mutation extracellular, you get 2 of the monomers binding together spontaneously and self-activating. So it's an activating mutation based on that. Or you can have a mutation in the tyrosine kinase domain that just starts phosphorylating things without ligand. And then you can have fusions, and this type 2 fusion is more relevant in bladder cancer. The type 1, type 2 just depends on whether it's N-terminal or C-terminal fusion. And it's not just bladder cancer. So if you look at the different cancers, for example, up here, breast cancer, you'll have FGFR1 amplifications in 19% of patients. In lung cancer, you see the same thing, FGFR1 amplifications. Big one is liver cancer, where you see FGFR2 fusions in 45%, which is a massive number. Almost half of patients, you have a clear therapeutic target, and some of the drug development has really focused on hepatocellular carcinoma for that reason. And then we see down here in bladder cancer, says 20% mutations. That's 20% in muscle invasive or metastatic. It's more in low risk bladder cancer, as we'll get to. So this shows just an overview again of the receptor, which is not that important, but you can see the hotspot mutation in 249C makes up 2/3 of mutations, and this is extracellular. And then there are two other most common ones. One is in the intramembranous portion, and one of these ones is, actually no, it's this one here, this 4.3 is also in the same region. So you can see it's all membranous or extracellular and not necessarily in the TKI domain. But look at the frequency of FGFR mutation in non-muscle invasive bladder cancer. It's extraordinarily high. So if you have a low-grade TA bladder tumor, up to 87% of tumors have a mutation. If it's intermediate, so intermediate means recurrent low-grade TA, it's 61%. If it's high-grade disease, so TA-T1, it goes down to 36%. In the TCGA, just in comparison, which is only muscle-invasive disease, it's 14%, which is relatively low. We often talk about it being around 20% in muscle-invasive disease. But you can see there's a clear correlation to stage and grade. And when you see these numbers in non-muscle invasive disease, it really screams out for a clinical trial to target it. Now, this is a busy slide, but I just want to highlight one thing. So this is a series of about, I think it's about 60 patients. So each column is a patient, and it's only TA bladder tumors. So they're sequencing only TA bladder tumors. And there's a lot of noise here, of course, but what you notice at the top, again, is that most tumors have an FGFR3 mutation. Those that don't, or even some that do, have a PIK3CA mutation, which is another just proliferation survival pathway, or, sorry, that one down there, or HRAS. So almost every tumor has FGFR3, PIK3CA, or HRAS, which are all similar pathways driving proliferation. This arrow in the middle is something that's very peculiar to bladder cancer, that you see frequent mutations in genes that modulate chromatin significance, but you see it across the disease spectrum, not dependent on stage and grade. Significance is not completely understood. But they're very genetically relatively homogeneous, the TA tumors that really appear to be driven by FGFR3. Now, if you look again, this is just to compare across the spectrum, and you can forget about most of the noise here, but FGFR3 is across the top. These are low-grade TA tumors, and you can see almost every patient has this or KRAS here. You see very little in the way of P53 and RB1 mutations, which are your classic mutated genes in bladder cancer. But as you go to high grade, you see it's less common. You do start to see some P53 mutations. When it go to high grade T1, you see a lot of P53 mutations and some RB deletions down here. And now your FGFR3 mutations are less than half. And then for muscle invasive disease, you only see occasional FGFR3 mutations and lots of other stuff, especially P53. So you see this interplay between different things. This is just showing in the TCGA, it was 14% mutated and 2% fusion. So not as common in the truly life-threatening disease. So fusions, so FGFR3 mutations are easy. Fusions are a little bit more difficult to understand. But what we see here is that there are different fusions. Alex Wyatt actually here in the lab described a fusion that hadn't been described before in bladder cancer based on circulating tumor DNA. But the classic fusion is FGFR3 with this TAC3. And the TAC3 by itself is not that important. It's an intrachromosomal duplication and fusion. So they're actually genes that are side by side anyway, and they sort of duplicate and reinsert. Makes it very difficult to detect by in situ hybridization, because usually you're looking for two things that will be far away that come together. But these are actually close together anyway. And what it does is it gets rid of an inhibitory region upstream from FGFR3, so it's just transcribed and translated without regulation. And that leads to downstream activation. Expression levels are very high, yeah. Without yeah. And if we take a step back again, so yeah, it's confusing if I go back and forth between FGFR3 specifically and FGFR, but it's not only about FGFR3 in bladder cancer. This shows in muscle-invasive disease. Again, each box is a patient. This is a TCGA. And you can see that FGFR1 amplification is actually fairly common. It's less well studied, but it also appears to be oncogenic. And then you can see that there are some FGFR2 changes, not that important. And then all the FGFR3 changes are over here. FGFR4 doesn't have a defined role. And then in non-muscle invasive disease, as I showed, it's mostly about the mutations. This is no longer TCGA. This is a Sloan Kettering cohort of 100 patients. Another just quick aside is that in upper tract, so on the left here you have upper tract urothelial carcinoma, on the right bladder cancer, and you see there are some differences that you see exactly the same mutations in both, just different frequencies. And of course, it may be just a selection bias is what I think. A lot of people think there's actually biological differences. But you can see FGFR3 mutations do tend to be a little bit more common in upper tract disease. And that'll be important later for treatment issues. The other thing is if you look at patients who are sort of pre or post treatment, you may see changes in different molecules, but also FGFR3. So this was a series from Sloan Kettering where they took patients who had neoadjuvant chemotherapy for muscle-invasive disease, and they compared those who had prior BCG to those who just walked in the door with muscle-invasive disease. And you can see here that the pathologic response post-BCG was only 26%, but for primary muscle-invasive disease, it was 45%. So the tumors that are resistant to BCG have been selected for resistance to chemotherapy, which hadn't been described before, but kind of makes sense. Those are the KM curves. So this is response, but this is actually recurrence-free survival. Again, if you've been pre-treated with BCG and have muscle-invasive disease, your outcome is worse. And they did some sequencing. Every tumor at Sloan Kettering gets sequenced. And the difference you see here that they focused on in their paper is ERCC2, which is a DNA damage repair gene. And we know that correlates to response with chemo. So treating with BCG, if you had an ERCC2 mutation, you're probably going to respond to BCG, and you didn't go on to get chemo. But if you failed BCG, you didn't have a mutation. So it correlates nicely that you're selecting out the responders already with the BCG and only non-responders go through. But in this context, they also looked at FGFR3, and you can see the opposite here. So the ones that have failed BCG have a high rate of FGFR3 alteration, mutation, compared to primary. Biologic explanations, not clear, but it is important if you look at some of the trials that are being done in more advanced post-treatment settings. Progression to muscle invasive. Yeah, they're all muscle invasive. So it's the selection of ones that progress. So just in summary on the actual alterations, it depends on context. So high grade, low grade. There's progression by stage, whether they're treatment naive or treatment failure, and then whether it's upper tract or lower tract. All of these factors play into how frequently the alterations are seen. So describing alteration, of course, doesn't mean that it's biologically relevant. It can just be associated, just be a passenger alteration. But different groups have shown that FGFR3 alterations are indeed oncogenic in models. This is just an example from Maggie Knowles, who has really led this field for years. She's in Leeds. And this just shows if you knock down FGFR3 with a specific shRNA here, you see a dramatic reduction in colony formation. And over here, if you add back mutated FGFR3, you see a reversal. So first of all, you see a ton of mutated FGFR3 expression, and any inhibition you see on migration or soft tissue, soft agar colony formation is reversed with the mutation. So it just shows that the mutation is actually impacting the biology. This is something I put in here just because we did this. So Killian Gust on the side there was my first postdoc in the lab. And we had looked at a North American cohort with, for the first description that these mutations are just as common in the North American cohort. But we also did some in vivo work. So this is a mouse model, and here we're using a monoclonal antibody targeting FGFR3 specifically, so it's not pan-FGFR. And then this one cell line that has UC1 here has overexpression of wild-type FGFR3. And you can see that the monoclonal antibody has a dramatic effect in inhibiting growth. The signaling, I won't get into any detail, but it also, you can see that there's less black over here, so it's blocking all the downstream signaling. The immunohistochemistry is Ki67, which is a marker of proliferation. So you can see there's less proliferation, which is also shown in the bar graph. So just another example that that FGFR3 is driving growth. And this was actually a primary xenograft that we created. So took a patient tumor, put it in the mouse, discovered then afterwards that it has the same hotspot mutation that we've been talking about, the S249C. And then again treated with either control antibody or the anti-FGFR3 antibody. You see a dramatic decrease in, this is tumor weight when the mice were sacrificed. This again is Ki67 looking at proliferation. So it's an anti-proliferative drug causing impairment of tumor growth. And again, some downstream signaling is blocked. So with all that background on FGFR in bladder, it makes sense that we should be trying to target it. We've known all this stuff for at least 10 years, and only now are we starting to see the inhibitors come into practice. But you can see the number of inhibitors. It's impressive how when we decide, okay, this is worth targeting, everybody jumps on the bandwagon. And you can see there are inhibitors that hit 1, 2, 3, or only 4. 4 doesn't appear to be relevant in bladder cancer. Not sure why 4 is different, but then a lot of the drugs hit all of the FGFR inhibitors, receptors, and then there are the dirtier multi-kinase inhibitors. There are also things, this is the antibody that I talked about now has a new name, and it is specific to FGFR3. There's another one from a competing company, and there's an antibody drug conjugate, so it's an anti-FGFR3 antibody loaded with a chemo payload. There are a couple though to highlight. So Dobinit, I'm just going to show, it was the first one that was tested in bladder cancer. Turned out to be a poorly potent drug that didn't really work very well. I'll show you that. And then infigratinib is one that I actually worked with in the lab as a fellow at MD Anderson that is now being developed clinically. This one we'll mention. Erdafitinib is the one that you need to know now, because it is FDA and Health Canada approved for patients with bladder cancer from Janssen. And rogaritinib we'll mention, and the AstraZeneca drug. So these are sort of the big ones that are out there. So Dobinit is TKI 258, and there was a lot of excitement of targeting FGFR3, and it really all fell flat on its face initially with this drug in bladder cancer. One of the first trials, so first of all, these first 2 trials were done in non-selected patients. So if you take just all comers and only 20% of them are going to have an FGFR3 alteration, it's probably not going to work very well. And so they went straight to BCG unresponsive disease. Don't know why, it doesn't seem to make a lot of sense to me. 1 out of 13 had a response, including 1 out of 3 with the mutation. Everybody had a grade 3 or greater adverse event, and it sounds like a great drug. And then in metastatic setting, they had 1 out of 44 objective response. I mean, that would really turn you off doing anything else with this drug, and as it did. This was in a bit of a breakthrough. This is from last year, where this is this BGJ compound I told you that I worked with as a fellow, initially made by Novartis, now by somebody else, I can't remember. But it was this was just a single-arm phase 2 trial in patients with second-line metastatic disease, and it showed some activity. Of course, it's selected only for patients with alterations, and you can see that, again, the usual alterations. And this is just a waterfall plot to show you some idea of the activity. So there is a good response here. So partial response or complete response together make up the objective response rate. And the objective response rate is 25% if you ask sort of the study reviewers to assess it, but 42% at the sites that were assessing it themselves. And there are a lot more patients who have stable disease. So then you talk about overall the disease control rate. And so it's a relatively good response, especially compared to what I just showed you with the TKI 258. There's a lot of interest specifically in the upper tract results of this trial. So it's only 8 patients, but you see that almost all of them responded or well, they all did respond or have stable disease. And so people are trying to read a lot into this, that maybe upper tract is more dependent on FGFR alterations. I say you have to be very careful with a sample size of 8. But the companies really are looking at, should we focus on FGFR, on upper tract for our next trials? I'd say the answer should be no.
Peter, is this these patients who've been pre-selected again for, you've already had chemo or checkpoint inhibitor?
They're post-chemo metastatic. Some of them have, a small proportion. I'll come back to that. So erdafitinib was tested in a somewhat larger trial. And I told you the last one was phase 2, but it was actually a phase 1 trial within a expansion phase, which is in all essence like a phase 2. But this is New England Journal paper that is also a single-arm phase 2 trial with, I think it was 99 patients. So, in bladder cancer, it doesn't take as much to get into the New England Journal as it does in prostate cancer. But the significance is that it's the first targeted therapy in bladder cancer. And the trial design is not completely straightforward. So patients were initially randomized to 2 different dosing regimens. Then they did an interim analysis and then treated everybody else with a 3rd regimen. So it's a little bit funny. But they discovered in this first phase that maybe 8 milligrams was the best dose to go, and then you could titrate up to 9 based on serum phosphate levels. So you're almost titrating up to toxicity to get the best effects, which the medical oncologists also do with the TKIs in kidney cancer. Final sample size that's reported on is this 99 over here, even though I think it was about 270 patients were treated overall. They used a panel. You have to define your marker that you're going to use, because that marker will be used moving forward for that drug. And so they used these alterations, which include the fusion, so the TAC3 fusion, but also another fusion here, and a couple of FGFR2 fusions, although very few patients actually had these FGFR2 alterations. And so the headline result here was a 40% objective response rate. And if you remember, in the same setting, the immune checkpoint blockade drugs have a response rate of about 20%, right? So it's already better than that. But what we really like about immunotherapy is that the response is often highly durable. And the question is, is it the same here? You can see that complete responses were rare, 3 out of 99, but there were a lot of partial responses. And again, a lot of stable disease. It didn't matter whether the patient had chemotherapy before, so the percentages are over here. If there was this hint, so 22 had immunotherapy, there's a hint of a signal that if you had failed prior immunotherapy, that you might actually do better with FGFR3 inhibition. I'll come back to that. And it didn't matter, that's all. We'll just skip over that. If you look at all the different subgroups, again, not that interesting, not much of a difference. Although, again, down at the bottom here, if you had prior immunotherapy, there's a hint of something. And this is where you look for the durability of response. So this is a swimmer plot, and in the immunotherapy trials, you have these patients who go on forever with a response, and that's what you're seeing at the top here. So the blue arrows means that the patients are still responding, but there are a lot of black X's down here, meaning that they've come off drug, and the orange squares actually mean that they've progressed. This one here is interesting because they've progressed, but they're still on treatment several months later. Anyway, the durability of response doesn't look as good, but some patients will do as well. The progression-free survival and overall survival is good for the second-line disease setting. So again, there typically hasn't been much to give here. Progression-free survival is about 5.5 months, which is actually better than immunotherapy. So many patients have absolutely no benefit that they progress very rapidly. So the median progression-free survival is very short. So that this would potentially be better as far as you can compare. And then a median overall survival in this setting of 13.8 months is quite good. Toxicity, just to highlight some, the things that we see here, so you have stomatitis, hand-foot syndrome, asthenia is whatever, nail dystrophy, and hyponatremia. The hyperphosphatemia I thought was in there somewhere too, but they're things that are very manageable. They may be very bothersome. They certainly impair quality of life, but you can titrate the dose down a little bit to get over the toxicity. So there's hyperphosphatemia is the top one here. So it's very common in lower grades, but not as common high grade. So toxicity is very manageable, although I'll come back to it a little bit later. Can we imagine giving this to our patients with low-grade GA tumors? A bit more of a question. So the FDA approved this in April of this year. And again, it was a milestone because it was the first targeted therapy approved in bladder cancer or urothelial carcinoma. And then Health Canada approved it just a couple of weeks ago, I guess now. And so it shakes things up a little bit as far as the treatment algorithm goes. So if we look at metastatic disease, this would be first-line therapy. So if a patient is eligible for cisplatin, they will get cisplatin. If they're not eligible for cisplatin, we should be looking at PD-L1 staining. So if they are eligible for carboplatin and they're PD-L1 negative, they would get carboplatin. If they're eligible for carboplatin but they're PD-L1 positive, they can get a checkpoint inhibitor. If they're ineligible for both carbo and cisplatin, they can get immunotherapy. So that's the current status right now of how we treat metastatic urothelial carcinoma. That's first line. And in second line, it then depends whether they've had IO first line or not. And this is changing, right? There are now trials of first line IO, but overall, vast majority are not getting first line IO. But now patients theoretically have the choice. Do they get an FGFR inhibitor or do they get a checkpoint inhibitor? And you can imagine looking at, so obviously if they've already had IO, then it's easier to say, if they've had IO in the first line, then they would get an FGFR inhibitor if they have the FGFR alteration. If they're IO naive, then you have to say, okay, well, do I go with the phase 3 positive trial that says that pembrolizumab works in all comers? Or do I go with, the marker-driven treatment? And that is an unanswered question. And there's another drug, just to mention, this enfortumab on the bottom here, is an antibody drug conjugate that looks very good with very, very compelling early phase trials that will also likely be FDA approved in 2020 and then probably Nestin-4. And Nestin-4, initially you had to demonstrate expression of Nestin-4 in the cancer to get on the trial, until they discovered that about 96% of patients of tumors had it. So they completely got rid of the marker. So it's an all-comers drug with response rates that look better actually than FGFR. Nestin-4 is. It's I think they're testing also in lung. And there is the results at ESMO of this drug plus checkpoint blockade that had about an 80% response rate. Small numbers, but still very, very compelling. That's what the vedotin is. Enfortumab vedotin. Vedotin is the toxin. Yeah. So one thing about all these trials is, in the PD-L1 space, there are all these single-arm trials, and no one sort of stopped to think whether PD-L1 expression was a marker of response to drug or whether it was just a prognostic marker. And Roche found out the hard way that it was more of a prognostic marker because they developed a big trial that was marker-driven, and basically the marker failed them. So here we also have to be careful. And the question is, do these FGFR3 alterations actually predict outcome regardless of drug therapy? And there are now a couple of studies that say, no, it's either a wash or maybe they even do worse. So this is from Italy, from Andrew Necchi, who has looked at 112 patients, I think it is, and you can see basically progression-free survival and overall survival. It doesn't matter if patients have FGFR alterations, yes or no. This is in the first line. The group from Janssen looked at this. So Foundation Medicine does genomic testing, and they can link to some clinical data, which is in the Flatiron EMR. And so they went back and looked at this, and you can see this is overall survival after any first-line therapy, whether it's chemo or immunotherapy. And 59 patients were FGFR altered, and 247 were not. And if anything, the median overall survival was a little bit worse, although not statistically significant, in the FGFR altered. It was important because if you think that FGFR alterations are more common in low-grade early disease, and everything we know about them, they're favorable, you could have imagined that you would actually be selecting for a more favorable cohort in the muscle-invasive spectrum, but that is not the case. Then here, so we have a marker to guide treatment in patients with metastatic disease, and we don't usually biopsy these patients. So the idea of determining their FGFR status by circulating tumor DNA is very attractive, and you all know that Alex White here works on this intensely. Again, the group from Janssen that has developed erdafitinib actually looked at this, and this one's from Janssen. And they used the commercial Guardant assay, which has very significant limitations, but it's still something to look at. They had all patients had to have FGFR alterations in the tissue to get on the trial. So we know that all these patients have that, and we have the tissue to compare to. But they did a next-generation sequencing assay of plasma, and they found a concordance rate of 56%. So not really good enough to be detecting alterations in all patients to get them on trial. You'd be missing too many. And the conclusion here was that it needs more work before it can be used clinically. They also did it in the BJG398 trial and found, again, not just the important numbers here, 68% were detected also by ctDNA. Not really enough because too many patients would miss out. And then everything I've told you up to now has been about sequencing, so looking at the DNA, whether it's mutation or fusion, less so copy number. One of the reasons we don't look at FGFR expression, FGFR3 expression by, say, immunohistochemistry is that the antibodies are no good, and no one's really developed a good assay for that, because you could imagine that just high expression of wild type would be a good marker for treatment, but no one has actually gone that way. But instead, groups have looked, or one company has looked at mRNA expression as a marker to select patients. And it's interesting because you're selecting out different patients, but they're still seeing good results. So the drug is regorafenib, and this was published in Lancet Oncology just over the summer. And they're looking at RNA expression by two different methods. And they've taken a bunch of different cancers, but you can see by far the biggest group here in the middle is urothelial carcinoma. They looked at 328 and found overexpression of FGFR, and it's not just FGFR3 here again, it's all FGFRs. They found overexpression in 50%, so much more than the 20% or so you would have found with a DNA-based test. This is interesting. So these are, and some of them, they had mutation data. So if you have an FGFR3 mutation, you always have overexpression. But you're also seeing overexpression in a lot of wild-type patients. So with this assay, you're picking up a lot of patients here that would not have been treated with the other drugs. And in the 51 urothelial carcinoma patients treated, you saw a 24% objective response rate, so lower than the 40% for sure. Almost half, though, had stable disease. I'm going to skip over that. Whether or not, so in the patients treated on this trial, whether or not the DNA was mutated didn't make a difference. So for patients with high expression based on RNA, it didn't matter if the DNA was mutated. And of course, again, you have to go back and look, what does RNA expression predict survival in the absence of these drugs and the TCGA? And the answer is not really.
I would have thought that something that you don't do actually look at expression levels in their signatures.
Well, they've looked. Well, I mean, they have an FGFR3 signature, like a multi-gene signature that would correspond to an activating mutation. It's not very robust because we don't have enough sort of mutated patients with gene expression. It doesn't. We've looked at it, but it doesn't really. I mean, it's never been looked at in a trial. But you could theoretically take one of these trial cohorts and then apply the signature to it. It might be more robust than just looking at the one mRNA. So towards the end here, I just wanted to touch a little bit on the interplay with immunotherapy. And you'll be familiar with the bladder cancer subtypes, right? So there have been multiple different subtyping mechanisms subtyping schema based on RNA expression. And they've all culminated in this recent consensus subtyping where all the groups have gotten together and said, okay, this is how we agree it should be done. And I just want to highlight the luminal papillary tumors off on the left here. This is about a quarter of all muscle-invasive bladder cancer, and they are characterized by FGFR3 alterations. That is the number one thing about them that separates them from the rest. They also have a lot of PPAR gamma alterations, which is a bit of a confounding factor when we look at immune regulation. The box down here in immune infiltrate is empty, which doesn't mean anything, but they are characterized by a lack of infiltration of immune cells. They are cold tumors, so non-inflamed cold tumors, or we also refer to them as immune deserts. So they're just very superficially, there's this very clear relationship between FGFR3 alterations and lack of immune infiltration. Over here would be sort of the opposite. The basal squamous are, and the luminal ones also have the best prognosis in the non-metastatic setting. The basal squamous are highly aggressive, rapidly proliferating, full of other mutations like P53 and RB1, but they respond well to chemotherapy. The luminal papillary, there are two trials up until now, Invigor 210 and Checkmate 275, that have looked at subtypes and response to treatment. And the one commonality that they have is that the luminal papillary tumors do not respond well to immunotherapy. And so there's this prevailing hypothesis out there that somehow FGFR3 mutations are making the tumors cold and they're able to evade immunotherapy. Let me skip over that one. And then there's sort of collaborating evidence like this again from the erdafitinib trial. And this comes to Ryan, to your point, that patients, so all the patients on the trial have an FGFR alteration. Some of them had been treated previously with PD-1, and they, so the patients with FGFR3 alterations had worse overall survival on PD-L1s, indicating that maybe we are selecting out for a patient population up front that does not have the immune infiltration that allows them to respond. This is, again, if you look at patients getting erdafitinib, there are 22 that had prior checkpoint blockade. The response rate was 4.5%. Usually we'd expect it to be around 20%. And in a different trial, with the regorafenib trial, it was also 11 patients with overexpression of FGFR3. They'd had prior immunotherapy. None of them responded. So again, sort of anecdotal evidence, small numbers, but it would indicate that if you have an FGFR3 alteration, you're not going to respond to immunotherapy. But in these contexts, you're only selecting for the patients who've already failed and gone on to the next trial. So there's a huge selection bias there. And I just put this up again because the implications would be, if you know that an FGFR3 alteration is going to make your patient resistant to immunotherapy, then of course in the second line setting, you would have those patients go on to erdafitinib instead of IO, and only the FGFR3 negative patients would get IO. So it's an important break point, but the evidence has to be solid. There are, since there have been a couple of studies that sort of put this in question. So again, in Bigger 210 and Checkmate 275, they went back and looked at the sequencing data of these two trials. They're large trials. And you can see that this is now a response to drug, so this is atezolizumab and nivolumab, based on mutation status. And basically the red and green at the bottom are the responders. And you can see whether you mutated or not doesn't make a difference for atezolizumab. And if anything, for nivolumab, the mutated maybe do a little bit worse. But there's no real difference. And there's no difference also in survival. So this really needs to be looked at. I don't think at this point we can say an FGFR3 mutated patient should get erdafitinib and everyone else should get IO. That we don't have enough data to suggest that. I'm going to skip over this for the sake of time. Then, so there are some interesting ongoing trials. So the erdafitinib approval is really a conditional approval. Janssen has to provide more data to get full approval later. And so there's a phase 3 trial, of course, ongoing. And it's interesting design because now you have this possibility. So patients will be screened for FGFR alterations. But then the big question is whether they've had PD-L1 treatment, anti-PD-L1 treatment, yes or no. If they have, they're randomized to erdafitinib versus second-line chemo, which is the only alternative. If they have not, they're actually randomized to erdafitinib versus pembrolizumab. And of course, there'll be a lot of markers in here. It'll be interesting to see how the biomarkers can drive treatment decisions. The Biscay trial was a trial that everyone was excited about. It was actually presented in preliminary form at ESMO just last month. This is one of these basket trials where patients with urothelial carcinoma come in. They have their DNA analyzed for specific alterations. If they have an FGFR alteration, they get either the FGFR inhibitor or FGFR inhibitor plus the checkpoint inhibitor, durvalumab. Also, these are DNA damage repair genes. You can get a PARP inhibitor plus durvalumab. Sort of the mTOR alterations, you get an mTOR inhibitor plus durvalumab. The nice thing about this trial is if you didn't have any alteration, which a lot of patients don't, you still got something because you went on to single-arm durvalumab. They wanted to show a 55% objective response rate in any given arm. And so you can see here that the 20% response rate to the FGFR inhibitor was not overly exciting, 15 patients only. And the combination was, I think, especially disappointing. There's 21 patients here, and they've only increased from 20 to almost 29% response rate. Neither of the others were overwhelming either. Durvalumab alone was where we'd expect it to be. So this was, it was a nice trial, nice idea. Finally, someone's doing a basket trial on bladder cancer, but it didn't pan out as well as we would have liked. Lots of adverse events. The big trials now are all combining immunotherapy plus FGFR inhibition for the reasons I said, and there's a list of some of them there. They're also now for the first time moving into earlier disease spaces. So this is where it becomes more and more relevant for us. So the BJG398 is being tested in an adjuvant trial, so post nephrectomy or cystectomy. And it'd be 12 months of oral therapy. I said that these drugs are well tolerated, but in a patient with no measurable disease in the adjuvant setting, it'll remain to be determined. And there are two trials in BCG failures, so BCG unresponsive disease. And again, here patients are faced with losing their bladder, yes or no. And so some of them certainly will be motivated to tolerate some toxicity, but there will be challenging trials to do. And then finally, Noah Hahn at Johns Hopkins is doing this sort of window of opportunity trial. This is now recurrent low-grade tumors, where you know the patient has had a low-grade tumor before. Chances are it was FGFR3 altered. And you're going to take the patient for a TUR, but you're going to treat them for 4 to 6 weeks with an FGFR inhibitor, much like Alan's trial with OGX-427. And then you'll see if there's tumor left, you'll biopsy it and see if it has an alteration. If it goes away, then presumably it had one. But the same drug has very significant side effects, and oral therapy seems challenging, but the companies are definitely working on intravesical delivery of similar drugs. So just in conclusion, FGFR3 is now mainstream marker and treatment target in bladder cancer. But I think there's room to go beyond FGFR3. We know very little about FGFR1 in bladder cancer, but it would appear to be relevant. These patients are not currently captured based on how we're selecting patients with FGFR3 and 2 alterations. Clearly, some of the tumors are addicted to FGFR, some are not. One of the low-hanging markers to look at is there are FGFR3 alterations across all subtypes. It's maybe only relevant in the luminal subtype. Maybe if you have an FGFR alteration and you're basal, it's just coincidence and it's not actually driving tumor growth. So there's some easy things to look at in that regard. I skipped over the part on treatment resistance, but there are specific mutations that cause resistance, and there are already drugs being developed to overcome those resistance mechanisms. Combination is going to happen for everything. Any single drug trial is really just a means to show that there's some activity before you do a combination trial. And then now we have, for the first time ever in bladder cancer, a question about how to sequence drugs with FGFR inhibition, chemotherapy, immunotherapy, and soon also the enfortumab. And that is it. Thank you.